Good morning. Welcome to today's lecture on study models. What are study models? Study models are essential diagnostic records which are accurate stone reproductions of teeth and their supporting soft tissues, which help in the study of occlusion and dentition from all three dimensions. Why do we make these study models? Study models are invaluable in treatment planning. With the help of these models, the occlusion can be visualized from the lingual aspect. These are permanent records of the intermaxillary relationship and of the occlusion at the start of the therapy. These are necessary for medical legal considerations. These are visual aids which help in patient motivation. They can be used for doing model analysis to calculate space discrepancies. They can be used when a patient is transferred from one clinician to the other and can also be used to simulate treatment procedure. What are the ideal requirements of a study model? A study model accurately represents teeth and surrounding tissues without distortion. They should be trimmed symmetrically on either side so that any asymmetries in the dentition can be easily identified. When placed on the back, they should reproduce the occlusion and they should reproduce the alveolar process as much as possible. The study models are further divided into two parts. They have an anatomic portion and an artistic portion. The anatomic portion consists of the actual impression of the dental arch and its surrounding structures. It consists of two-thirds of the total height of the cast. The artistic portion consists of symmetrical plaster base that supports the anatomic portion and helps in analyzing occlusion and the orientation of the casts. It constitutes of one-third of the total height. Steps in the construction of study models. These steps are impression making, taking a wax bite, disinfection of the impression, casting the impression, basing and trimming, finishing and polishing. Impression making. Obtaining a good impression of the hard and soft tissues of the dentoalveolar region is an important factor in the proper fabrication of orthodontic study casts. The impressions should extend to the limits of the buccal sulcus and into the lingual sulcus of the lower arch. The maxillary impression should cover the hard palate but not extend onto the soft palate. Hence, it is recommended to use high flange orthodontic trays which extend into the buccal and lingual sulci. The trays selected should include the last eruptive molars and have a clearance of around 3 mm between the teeth and the tray. Irreversible hydrochlorides such as alginate are widely used for impression making. During the procedure, the patient is seated in a vertical position to avoid entry of impression material into the pharynx. Now coming to disinfecting the impression. After the impression is made, it is rinsed thoroughly in water and is then disinfected to free them of microorganisms, plaque and other oral secretions. It is then soaked in a disinfectant solution such as biocide. The duration for which it should be soaked can be ascertained from the manufacturer by the details given on the disinfectant bottle. After disinfection, it is again rinsed in water to clear any residual disinfectant. This is followed by casting the impression. The impressions are casted using orthodontic stone or model stone. It is beneficial to use some kind of vibrator to eliminate incorporation of bubbles. In the absence of a vibrator, the impression should be continuously tapped while pouring the stone into it. After this, the next step is basing and trimming the cast. Once the anatomic area is poured, the artistic area is built. Base formers are available for this purpose. Once the anatomic portion is poured, the impression tray is turned upside down and pushed into a plaster filled base former, which is then allowed to set for 30 to 60 minutes, followed by trimming. First step in trimming is to determine the occlusal plane of the dentition. The occlusal plane is considered to be the highest 3 points of the erupted teeth. Once this has been determined, the base of the lower model is trimmed parallel to the occlusal plane. Then we trim the back of the lower model perpendicular to the base. The midline of the lower model should normally correspond favorably with the upper mid-palatal raphe. It is generally easier to locate the midline in the max recast. The back is trimmed so that it is at 90 degrees to the base of the model and has a minimum of 5 mm distance from the most posterior tooth. With models in occlusion, trim the upper back so that it is flush with the lower back. Trim the posterior surface of both models until you are just posterior to the hamler notch, which should be several millimeters posterior to the last tooth. Place the upper model on its back on the model trimmer. Trim until the top base is flat. Occlude the models and check for parallelism of the bases and so that the backs are in flush plane. This is followed by making buccal cuts on the edge of the vestibule at a 60-degree angulation. The edge of the vestibule is taken as a point approximately 5 to 6 mm away from the most prominent point of the lower canine or first bicuspid tooth, whichever is more prominent. The anterior section is trimmed from canine to canine in the form of a smooth curve. The heels of the lower model are cut at approximately 115 degree to the back of the model. Make buccal cuts at the edge of the vestibule. Similar to the lower model, make buccal cusps at the Similar to the lower model, make buccal cuts at the edge of the vestibule at 60 degrees to the back of the model. Make the anterior cuts so that the ends are at the midline approximately in the canine area. This cut should be approximately 5 to 6 mm from the labial surface of the anterior teeth with both sides of equal length and their intersection at the midline. The heels of the upper model are formed by occluding both the models and finishing them such that they are flush with the heels of the lower models at approximately 115 degrees. The heels of the upper model may not be at the same length as those of the lower model. This is followed by making anterior cuts, the ends of which should be at the midline and at the middle of each canine. The occluded models should have a sharp 90-degree angulation between their base and back, which is then followed by finishing and polishing. The artistic portion is polished using a fine grained sandpaper. Be careful to not round off the edges. Final polishing is done by placing the casts in a soap solution for 1 hour, followed by rinsing them in warm water. They are then allowed to dry and then are buffed for a smooth and shiny appearance. Coming to model analysis. Model analysis involves the study of the maxillary and mandibular dental arches in all three planes and is a valuable tool in orthodontic diagnosis. Model analysis is further divided into permanent dentition analysis and mixed dentition analysis. The permanent dentition analysis include arch perimeter analysis, caries analysis, Ashley-Hose analysis, Pons analysis, Linderhart's analysis, Korkos analysis, and Bolton's analysis. Whereas the mixed dentition model analysis include Moyer's mixed dentition analysis, Tanaka-Johnston analysis, Nance mixed dentition analysis, Hokaba's mixed dentition analysis, the radiographic method. Coming to Bolton's analysis. According to Bolton, there exists a ratio between the mesiodistal width of the maxillary and the mandibular teeth. Many malocclusions occur due to abnormalities in tooth size. It helps to determine the disproportion in the size between the maxillary and the mandibular teeth. First, the sum of the mesiodistal diameters of 12 maxillary teeth and the sum of the mesiodistal diameters of the 12 mandibular teeth, including the first molars, are determined. In the same manner, the sum of the 6 maxillary anterior teeth and the sum of the 6 mandibular anterior teeth from canine to canine are determined using dividers, a pair of dividers, or a Bowley's gauge. Then we calculate the overall ratio. The sum of the mesiodistal widths of the 12 mandibular teeth should be 91.3% the mesiodistal widths of the 12 maxillary teeth, according to Bolton. This ratio is calculated using the formula overall ratio is equal to sum of mandibular 12 upon sum of maxillary 12 into 100. If the overall ratio is greater than 91.3%, then the mandibular tooth material is excessive. The amount of mandibular tooth material excess is calculated by using the formula mandibular overall excess is equal to sum of mandibular 12 minus sum of maxillary 12 into 91.3 divided by 100. If the overall ratio is less than 91.3%, then the maxillary tooth material is excessive, and this is calculated by sum of maxillary 12 minus sum of mandibular 12 into 100 upon 91.3. Then we determine the anterior ratio. This ratio is calculated by the formula anterior ratio is equal to sum of mandibular 6 upon sum of maxillary 6 into 100. The sum of the mesiodistal diameters of the 6 mandibular anterior teeth should be 77.2% the mesiodistal width of the 6 maxillary anterior teeth. If the anterior teeth ratio is greater than 77.2%, then the mandibular anterior tooth material is excessive. The amount of mandibular tooth material excess is calculated by using the formula mandibular anterior tooth material excess is mandibular anterior tooth material excess is equal to sum of mandibular 6 minus sum of maxillary 6 into 77.2 upon 100. Now, if this ratio is less than 77.2%, then the maxillary anterior tooth material is excessive, and the amount of maxillary tooth material excess is calculated by using the formula maxillary anterior tooth material excess is equal to sum of maxillary 6 minus sum of mandibular 6 into 100 upon 77.2. Coming to the caries analysis. According to caries analysis, the arch length tooth material discrepancy is the main cause for most malocclusions. This analysis is usually done in the lower arch. When the same analysis is performed in the upper arch, it is known as the arch perimeter analysis. First, we need to determine the arch length. The arch length is determined by measuring anterior to the first permanent molar using a soft brass wire. The wire is placed touching the mesial aspect of the lower first permanent molar, then passed along the buccal cusps of the premolar, the incisal edges of the anteriors, and finally continued the same way up to the mesial of the first molar on the contralateral side. The brass wire should be passed along the cingulum of the anterior teeth if the anterior teeth are proclined, and along the labial surface of the anterior teeth when they are retroclined. The mesiodistal width of all teeth anterior to the first molar are measured and summed up as total tooth material. The difference between the arch length and the actual measured tooth material gives us the discrepancy. And this discrepancy is then interpreted as the amount of discrepancy between the arch length and tooth material. If the arch length tooth material discrepancy lies between 0 to 2.5, then proximal stripping can be carried out to reduce the minimal tooth material excess. If it lies between 2.5 to 5, then extraction of the second premolar is indicated. When this discrepancy is greater than 5 mm, extraction of the first premolar is usually required. Coming to the Ashley-Ho's analysis, Ashley-Ho considered tooth crowding to be due to the deficiency in arch width rather than arch length. He found a relationship between the total width of the mesodistal diameters of teeth anterior to the second permanent molars and the width of the dental arch in the first premolar region. The first step in this analysis is to determine the total tooth material. It refers to the sum of the mesodistal width of all teeth from first premolar to the first premolar. Refers to the sum of the mesodistal width of the teeth from the first molar to the first molar, inclusive of the first molars, which is taken on the cusps of the dental arches. The second step is determination of the premolar diameter, PMD. It is the arch width measured at the top of the buccal cusp of the first premolars. The next step is determination of the premolar basal arch width, PMBAW. The canine fossa is found distal to the canine eminence. The measurement of the width from the canine fossa on one side to the other gives us the width of the dental arch at the apical base or the junction between the basal bone and the alveolar process. If the canine fossa is not clearly distinguishable, the measurement is made from a point that is 8 mm above the crest of the interdental papilla distal to the canine. We then compare the premolar basal arch width and the premolar diameter. If the PMBAW is greater than the PMD, arch expansion is possible. But if the PMAW is lesser than the PMD, arch expansion is not possible. To achieve normal occlusion with full complement of teeth, the basal arch width at the premolar region should be 44%, the sum of the mesodistal widths of all teeth mesial to the second permanent molar, which is determined by a formula. PMBAW percent is equal to PMBAW into 100 by total tooth material. If this percentage is equal to or less than 37%, it indicates need for extraction. If this percentage is 44% or more, it indicates non-extraction treatment plan. If this percentage lies between 37 to 44%, the case is referred to as a borderline case. Coming to Moyer's analysis. The Moyer's analysis is a mixed dentition analysis. The purpose of a mixed dentition analysis is to evaluate the amount of space available in the arch for the erupting permanent canines and premolars. Here, the size of the unerupted permanent cuspids and bicuspids are predicted from the knowledge of the sizes of certain permanent teeth that have already erupted. This analysis predicts the combined mesodistal width of 3, 4 and 5 based on the sum of the widths of the 4 lower permanent incisors. To calculate the space available for 3, 4 and 5, which is the cuspids and the bicuspids, the mesodistal width of the lower 4 incisors is measured and summed up. After the incisal alignment, the distance between the distal surface of the lateral incisor and the mesial surface of the first permanent molar is measured. Based upon the mesodistal width of the 4 mandibular incisors, the expected width of the first premolar, the second premolar and the canine is predicted by referring to the probability charts. Up to 75% of probability is considered reliable. The predicted tooth size of 3, 4 and 5 is compared with the arch length available. If the predicted value is greater than the available arch length, crowding of teeth can be expected. Thank you.